Kim Rathmell. I'm the CEO of the James Cancer Hospital and director of the Ohio State University Comprehensive Cancer Center. I've been here about 8 months, and I am just delighted to be here. And the thing that really puts it over the top for me, and I say this over and over again, is our community and how much our community loves to come together, to experience everything that there is in life together, to problem solve together. And so here we are together. This is why I came to the James, and why I came to Ohio State was to make a difference, and to make a difference in a way that empowered the community to be a part of what we do and to be a part of the solution for cancer. So today, if we think about cancer, we think a lot about a scary illness. We think about treatments that are toxic and potentially dangerous, but we also spend a lot of our time thinking about life after cancer and thinking about survivorship. And that's what we'll be talking about today. So I'm going to just take one step back. So decades ago, and even not that many decades ago, when we thought about cancer treatment, it started with surgery, cut it out. We moved on to chemotherapy, toxins that could kill a rapidly dividing cancer cell, and radiation. We could laser zap it and use radiation to get the cancer. That made many improvements. Then we learned a revolution about the genetics of cancer. We learned how to apply precision-based methods, targeted therapies, things that could really tackle the cancer cells very, very specifically. But what was the biggest transformation of the most recent era is moving to immunotherapy, taking our own immune system and turning it to recognize the cancer as something foreign and something that it can tackle. We knew all along that it could do that because there were examples where that happened naturally. Not very many, not nearly enough. But learning how to take control of the immune system has been really game-changing. We do that in a lot of different ways today. We have drugs that will take the brakes off the immune system and just say, go, go, go. We have technologies where we take cells from a patient's immune system and re-engineer them, like in Star Trek, to focus directly on the cancer and everything in between. And that's really been revolutionary for all of the things that we do in the cancer space. And it's also given us a whole different way of thinking about cancer. I mentioned that we think about survivorship today. The American Cancer Society just released its report showing that 70% of patients will live at least 5 years with cancer. So people are living with cancer. We know that there are nearly 20 million survivors of cancer in the United States today. And these treatments that we've applied, surgery, chemotherapy, radiation, targeted therapy, and now immunotherapy, impact patients in all kinds of different ways. And we see that as an opportunity for us to rethink cancer and to think about how we really take the whole life and make the optimal treatments available for our patients who have experienced cancer.
I'm Alexa Meara. I'm the rheumatologist that lives in oncology. Interesting is a choice word that some people say. I think other people may say difficult or mouthy, but I am here to be able to really talk about the fact that we are going to listen to stories today about the new era of cancer. And the James brilliantly saw this and saw the vision and embedded a rheumatologist 4 years ago into the oncology to take care of the continuum of the cancer care that's required for patients on immunotherapy. We are, and the only one that's fully embedded that I know of, but we're, with the foundation and James as the model, this could be the new normal as we move forward. And the exciting point is people are living. This is the most important thing. People are living. And now we have an opportunity and our responsibility to help them live well. And that is the heart of why we are here and the stories we are going to hear today. I have to at least thank a few people here. One, the James Cancer Center in Ohio State is when they allowed me to do this. They pay me. That's really, really important and to be here and partner. The Foundation for Autoimmune Cancer Support, the board, the Columbus Foundation, the Friends of Alexa that have just stepped up to make this happen. Ruth, Jen, everyone, thank you. Doug for agreeing to be here. I truly appreciate that. My husband who puts up with me as well. Everyone's trying to wrangle me to get this vision to happen. I follow commands mostly. And our industry partners, right? Because we wouldn't be here without the drugs that are made. So Meso and AbbVie and Janssen, very important that they get to be here and to move us forward. And the stars of the show are our patients. And I picked 4 patient stories that tried to have the continuum of the different types of autoimmune side effects these cancer treatments can cause, because I think it's hard when you hear the word autoimmune, you don't know what that really means. And so we're briefly going to talk, each patient's going to talk, and it will be Cindy, Rich, and Melissa will be giving Jody's story. And then we will have Kara last, and then that's when, after that, we'll have the discussion where you guys can ask questions, so please hold to the end. And so with that, I want to say thank you again to Dr. Rathmel, to the James. We're here, and we will begin while you're all here to hear the remarkable stories from our patients.
I'm Cindy Vinco. Thank you for that smile. I was diagnosed, summer of 2020. Taking care of my grandkids, I noticed a mole was changing on my arm. And it was the middle of COVID, of course. Everything happened then. I called my dermatologist, asked if I could get in early, and he had no appointments until my standing appointment in October, so I had to wait. He took one look at it and said, I'm going to biopsy this right now. So I knew that wasn't a good sign right away. Very shortly after that, I got the diagnosis of melanoma. If you want all the technical things, I'll tell you later, like nodular and stages and all that. But thankfully, he referred me to the James, and I cannot say enough good things about every person that has touched me there. Just an amazing group. I had surgery, had that removed, lymph nodes removed, and the cancer had spread to my lymph nodes, so they recommended I have a year of Keytruda. And so that went just wonderfully. I flew through Keytruda, hardly any side effects. It was amazing. I had a year then with clear scans, yay. And then a year later, it was back. The treatment this time was Braftovi and Mektovi, which is a targeted therapy for a gene mutation that I have. And I didn't have any bad side effects from that either. I got curly hair, and I saw things, which was kind of fun, but gradually they stopped that treatment because of the little weird side effects, but my CTs were clear again, and I went another year with no evidence of a disease. Then October of 2025, one day, just a lymph node. I could feel a lymph node overnight. So I called my dear oncologist's office, and love her, and the next treatment is Ipi-Nivo, which is a immunotherapy as well. And they sent me home with a stack of warnings and told me, this treatment can change your life. It can be life-altering. You can have side effects that you will never get over. And I was well and fully warned, but I didn't feel like I had a choice. I had things to do. I had grandchildren to help raise, and turns out that I learned more from them than they learned from me, but that I needed to be here. So I signed up, and went for it. First 2 treatments were fine. The 3rd treatment is when the pain started. And that's when I got to meet Dr. Meara. My oncologist sent me to her. And I was a little confused about why at first, but I got it pretty quick. She's a dynamo. She started me on PT. I had sciatica and fireworks in my legs, and for the first time in my life, I was willing to take painkillers. I hated to even think about it. That was the 3rd treatment. The 4th treatment is when I lost myself. It was like, well, Dr. Meara says I had a cascade of side effects. You name it, it shut down. I spent 30 days in the James between January and April. I had diarrhea. I never talked about poop so much in my life. I'll tell you what. Describe it. What color is it? 8 times a day. Such terrible pain in my hands, my arms, every part of my body. Weakness, confusion. I'm looking at my husband. He's going, yeah, you were confused. I would fall asleep talking to my doctors or in the bathroom. Just tune out, go to sleep. I had no taste, no saliva, no tears. I lost my hair. My eyes were inflamed. The ophthalmologist would come in and look and say, I can see the blood vessels bursting in your eyes. My joints were swollen, my jaws, my knees. My knees looked like, they were bad. And I couldn't, what happened finally is that I couldn't get out of bed, and we called the squad, and I couldn't even use my arm to take the covers off. It was that bad. Tony was my advocate through the whole thing. He was in the hospital every single day. He carried me out to the EMS because I didn't think they could do it like he can. He has a little red notebook that he recorded every medicine, every doctor term he could come up with that somebody said. He would write it down, and then we'd look it up later. If I wanted to know what I had taken, I asked Tony because he knew. So I'm in the hospital. They're trying to figure out what's wrong with me. They tested me for everything from C. diff to parvo, and what the cause was the immunotherapy. And this is when Dr. Meara really kicked in. The people at the hospital would come in and say, Dr. Meara wants us to try this, or Dr. Meara wants us to try that. And so many different things all at once, and I couldn't keep track, but he did. But I had 2 advocates. I had him, and I had her. Where is she? Is she here? Well, and her relationship with Tony is amazing too. She would come into the room. She would see Tony. She would face her body toward him and ask him how he was doing. Does he need anything? She was so, as well as being tuned into me, she was tuned into him, and I appreciate her so much for that. So I can't even tell you, well, I can tell you some of it. I know she gave me Plaquenil and Kevzara and IVIG, but I can't tell you everything. Look in his book. And then gradually, well, the first time I had to go back to the oncologist, I needed a wheelchair. I couldn't make it to the 4th floor without a wheelchair. But gradually and almost imperceptibly, I got better. little tiny things I could notice. Oh, I couldn't do that before. And it changed from the wheelchair to the walker. And I had to do one of those rocks up from the chair to get up into a standing position. Then there was a cane. And then, now we're hiking again. Now we can hike. Dr. Meara tried everything. She gradually tapered me off steroids. And here I am. I feel very healthy.
Can we have Tony come up?
Oh, please.
Do you want to give it to him? Yes. Do you want to give it to him?
Good for you.
You get to go sit with him.
Oh, good. Yeah, you want to read this last card for me? It's the important stuff.
Go for it.
We need research. We need research to help record all of these side effects and what actually helped us. This doesn't need to be in silos, you know? I had to have my support group on Facebook, and some of them are still suffering with these side effects that you helped me with. They need the information she's got in her big old brain. And I'm so grateful to the James for being so close, being able to be part of such a world-class hospital is it's beyond words, yeah. So please, if you have a place in the job that you do, if you're a nurse or a doctor or a fundraiser or an administrator or whatever it is you do, please, this is my challenge to you to bring all this information together, to do the research and share it with other doctors in the James and outside. Thank you very much.
My name is Rich Wright. I'm really grateful for the opportunity to be here this afternoon. I want to thank Dr. Rethmel for being here. It's very important. Thank Dr. Meara, the board. This is an opportunity that, frankly, I was looking for and didn't know I was looking for. Trying to figure out a way to give back and help others, hopefully so that others don't go through what some of us have faced. I was diagnosed with cancer, kidney cancer, in December of 2022. They removed my right kidney shortly after the first of the year. There were no treatments at that time that were recommended. They felt that the tumor was encapsulated enough that I would probably be fine. Went through the normal routines with scans and blood test follow-ups, and a little less than a year and a half later, the cancer returned, and it was in one of my adrenal glands. In between that time, my wife and I had relocated to the Columbus area, New Albany, and I made the decision that I didn't want her to have to travel back to the Cincinnati area while I went through surgeries and treatment, and asked for a referral to the James. It took a little while for the referral to come through, but when it did, things started to move pretty quickly. They removed the adrenal gland, and about 6 weeks after the surgery, I had my first infusion with Keytruda. The first couple treatments went relatively well. I had a pretty significant rash, chilling, but I thought, okay, if it doesn't get any worse than this, I can handle it. I can make this through. After the third treatment, things started to change, and they started to change pretty rapidly. It started to attack my major joints, my knees, my ankles, excuse me. Swelling was unbelievable. I couldn't believe how swollen my legs would get. I ended up slitting my shoes so I could get my feet into my shoes. I was so swollen. As I talked to my oncologist about it, he said that, some of these reactions were normal. He prescribed some steroids, took the steroids. They did help with the swelling. They helped somewhat with some of the pain I was experiencing. But within 36 hours of the prescription being depleted, I was right back where I started, and sometimes worse. By the time I got through the 5th treatment, I was almost immobile. I had started to use crutches to get around. At that point, I couldn't dress myself. I couldn't feed myself. I was totally reliant on my wife. And I don't know what I would have done, frankly, had she not been as strong in character. And even though she's not a very big woman, she's got a lot of courage and strength. I talked to my oncologist more about what I was going through. And I think he's a very bright man. I don't think he was really listening to me. He referred me to an orthopedist, had x-rays taken of my left knee, which I knew needed to be replaced before the cancer hit me, but I also knew that wasn't really the problem. By the time I got to the 6th treatment, things deteriorated pretty rapidly. I couldn't raise my hands over my head. My hands were swollen like paddles. I couldn't answer my cell phone. I couldn't text my children. I was bound to a chair 24 hours a day. To use the restroom, my wife and I devised some makeshift gadgets to help me get up, and she would get me to the restroom. She would get me on and off the toilet, which was something I didn't think I'd ever experience in this lifetime. Something I didn't think I would ever have to put her through, frankly. It worsened to the point that one evening I was sitting in my chair, the prescription of steroids had run out, and I could feel it coming on again. And I told my wife, I said, I think I can shave, and I think I better do it tonight because I'm not going to be able to move tomorrow. And she helped me into the bathroom. I shaved. By midnight that night, I was completely immobilized again and in so much pain that I can't explain it to you. The pain was such that if she would try to help me and dress me, I would literally scream. I've never felt such intense pain. And I have a very high tolerance for pain. After both the surgeries, I took one pain pill and ended up disposing of the rest of the pain medication. It doesn't affect me that greatly. But this did. Ended up being admitted to the James, was there for 3 days, and various tests were run. And they sent the hospital rheumatology team in, some students, and then the lead doctor on the case. And they prescribed some medications that I was given intravenously in the hospital. I felt pretty good fairly rapidly with the intravenous treatments. Went through some physical therapy while I was there and was released. And I was released with a referral to Dr. Meara. I wasn't quite sure why. I didn't feel like it had been explained to me what they suspected I had. But when I sat down with Dr. Meara, she asked me what I had gone through. I explained the whole story to her, and she took her time and listened, and was, for the first time, I felt like somebody was hearing what I had to say. And she asked me how I was feeling, and not to be vulgar or crude, but I told her, I said, I'm pissed. I said, I've never been this angry in my life. And she assured me that I wasn't alone, because frankly, the way my oncologist had reacted, I felt like this was something that was unique, and I was by myself, frankly. She started the process of tapering me off of steroids and prescribed some hydroxychloroquine and weekly injections of Tyen. And I began the slow process of recovery, going from a wheelchair to back to crutches, and then eventually with a cane. And the complex we live in has extremely long hallways, and I think the people in the complex thought I was some kind of ghoul, but I started walking those hallways religiously all day long, trying to get my balance back, somewhat teaching myself to walk again, getting my strength back, and eventually, working with Dr. Meara, I was able to abandon the cane. I don't know how people deal with this if they don't have a spouse as strong as what Vicki was, my wife was for me. I don't know where I'd be today without her, frankly. I certainly don't know where I would be today without Dr. Meara. I'm especially grateful for her ability to listen, her courage. I think what she's tackling, taking on, takes a tremendous amount of fortitude, and I'm grateful that she has that. I'm really appreciative that Dr. Rathmel is here today to hear these stories. I think there's an opportunity for teaching to come out of all of this. I've encountered numerous medical students at the clinic and at the James, and I hope that these stories are shared with them. I think there's an opportunity to turn the tide so that no one else has to deal with what we've had to deal with. And as it onsets, it's addressed more quickly, that the person over here is talking to the person on the other side, and they're communicating with each other openly, and things aren't so siloed. They don't need to be that way. I was in business for many years, and I worked hard to tear down silos. And I think that's part of what we need to do here. These immunotherapy drugs are rolling out so quickly. And I think that while there is some understanding of what the side effects are, they don't affect any two people the same. And I think that understanding has to come to the forefront. I think that part of the learning has to be that patients know their bodies. And when they tell you something, they're not telling you because that just makes them feel good to vent. They're telling you because they're looking for help. And I was looking for help. Dr. Rathmel has a tremendous load to carry in the position she's in, but she also has a tremendous opportunity. And I hope that with what we're doing today, that this is a step forward where people can start to move away from what we've had to experience, and in the beginning know that they can go through these treatments without the agony, frankly, that we've faced. I want to thank you again, Dr. Rathmel, for being here today. Vicki, if you would, I'd like for you to come up and thank you for everything you've done. I just don't know where I'd be. 50 years of marriage, I never thought I would ask her or put her through what I put her through this last year. She's a big fan of being in front of crowds, too. Thank you. I love you.
Good afternoon, everyone. My name's Melissa Muth, and I am speaking for Jody Karen Buchanan. Boy, I have a loud voice. I've known Jody since 1979 when we met here at Ohio State and we were sorority sisters. So we've gone through all kinds of things, good, bad, the ugly, you name it. So I would like to thank everybody for being here today, and I'm going to read you Jody's story in the form of a letter that she wrote. So it's going to be in first person. Myself, I'm very passionate about cancer. Fortunately, I do not have it, but I've lost way too many people to it that I love and cherish. And I'm a James ambassador. I also have ridden every Pelotonia. I think 2 I didn't because I was out of the country. But I'm a high roller Pelotonia rider because I love the ride and I love the whole thing. So thank you. Got to put my readers on. So this is Jody's story. Good afternoon. My name is Jody Karen Buchanan. Thank you so much for listening, and hopefully something will come out of this. My cancer journey started in July of 2022 with some blood in my urine. A scan showed a tumor in my right kidney, which was removed in October of 2022. The surgeon thought that all the cancer was removed. Originally, the cancer was typed as renal cell carcinoma unclassified because it wasn't clear. After recovering from surgery, my James oncologist did a preliminary scan to ensure that all the cancer was gone. It was not. He started me on Cabometyx. Roughly 2 months later, I had my first of 12 immunotherapy infusions. 12 infusions of nivolumab between early 2023 and March 20th, 2024. Early on with immunotherapy, I started having high blood pressure. Then my teeth started to fall out. In the early summer of 2023, I had multiple occurrences of breathing issues. I do have asthma. But no one knew the actual cause of this. Was it the blood pressure meds? Was it the immunotherapy drug? Who knew? I had taken hydrocortisone for my asthma, but very sporadically. So the immunotherapy kept going. In June of 2023, I achieved a complete response, but treatment continued. In mid-2024, during a routine visit with my oncologist, I told him how I was falling asleep at weird times, in the middle of conversations, in the middle of eating, you name it. My symptoms weren't taken very seriously, but I was adamant that something was wrong. I know my body, something was wrong. I was referred to an endocrinologist who said to take less cortisone and come back in 6 months. Fortunately, I was also referred to Dr. Meara, who actually ran tests and determined that I have adrenal insufficiency and need to take higher doses of hydrocortisone. Save number 1. In February 2025, I went to Houston to see my son and grandkids. The kids ended up with colds or norovirus, as it was apparently making the rounds in the school down there. For the first 2 days, I was fine. Then I woke up violently ill. I stayed in bed and could barely drink water, much less eat. I was in serious trouble. When my daughter-in-law noticed that my lips were turning blue, they called an ambulance and I was taken to the hospital where I stayed for 5 days. I was in ICU for 3 of those days. I was not responding to any medications, no treatments, nothing was helping. At some point, I was able to tell my medical staff there that I had adrenal insufficiency, and they started pumping the hydrocortisone through IVs. Both the doctors there as well as back here said that I was at death's doorstep. Once I came back here, I continued the IV of cortisone for some period of time. Literally a month later, I had a bloated stomach and felt horrible. Another routine visit with my oncologist was not taken very seriously, so I contacted Dr. Meara, who referred me to a pancreatic MD, who did the proper investigation and testing and found out I had acute pancreatitis. Save number 2. This past summer, A routine CT scan found a tumor in the retroperitoneal cavity. By this time, I had found and actually visited an RCC specialist at MD Anderson who typed my cancer as the more rare chromophobe RCC. He suggested a low-dose radiation for 3 weeks as opposed to 3 megadoses of radiation suggested here. So I went to MD Anderson for that radiation treatment. Shortly after that radiation was complete and I was home, I started having bad back pain. I thought I slept wrong. I thought it was a bad mattress. I thought something, but I couldn't lay flat. I couldn't sleep. I had to sleep prone. Dr. Meara was able to get me admitted into the James, and she ordered an MRI, save number 3. She also prescribed the right type of drugs that allowed me to lay flat on my back during the duration of the MRI. The MRI revealed a tumor entwined around my T4, T5, and pressing against my spinal cord. Surgery occurred literally 3 weeks ago, and that's why Melissa's speaking here today. Immunotherapy drugs can be lifesavers. We know this. But their side effects are not well known, well researched, well communicated, nor well addressed. Please help fix this. So many side effects are devastating and permanent. My adrenal insufficiency is permanent. They're toast. Docs, please listen to your patients. Our issues are not imaginary. We need all specialist doctors to reach outside of their expertise areas to help mitigate these immunotherapy side effects. 1 full year of immunotherapy was devastating to me. We definitely need more Dr. Mearas who are willing to address these issues and bridge the gap between specialists and the side effects of the immunotherapies that they prescribe. Please support Dr. Meara's work. Thank you.
As Jody and her husband are not here, she will take them back to her from there.
My name's Kara Corpse, and I was 38 years old in 2021 when I was diagnosed with triple-negative breast cancer. The first meeting with my wonderful oncologist went about like you would expect it to. My husband Patrick and I showed up with anything that a patient and a caregiver might have. Fear, sadness, trepidation, but we also had a lot of knowledge. Professionally, I'm actually a comparative immunopathologist. That means that I'm a veterinarian who's a boarded pathologist with expertise in pathology across many different species, including people. And I have a subspecialty in immunopathology, the pathology and physiology of the immune system, and I had a special interest in immunotherapy already. So when my oncologist recommended that we add a checkpoint inhibitor immunotherapy to my treatment regimen, I actually just approached it like a scientist and asked a bunch of questions. She showed me data from published large-scale clinical trials with hundreds of thousands of patients. She showed me her unpublished data in studies that were being conducted here in the James under her expert guidance and the guidance of other people working in this field. And so we asked some additional questions about it. What does this mean? What does the data tell us? It was very clear that immunotherapy provided a benefit to disease-free survival, and it reduced the risk of cancer coming back if you got immunotherapy. In those clinical trials, patients had reported that immunotherapy was actually quite easy and that severe side effects were relatively rare. So we asked additional questions because, as Dr. Meara has mentioned, I wasn't a normal patient. What about patients who have a pre-existing autoimmune condition like me? The data at that time said I was at no greater risk than any other patient receiving immunotherapy. And so because all of that data was really compelling, we moved forward. I want to be clear with everybody that's listening. I don't regret for 5 seconds the treatment choices we made. Everybody in the room at those appointments, save for perhaps Patrick, although he was really educated at that point, was an expert. I was an expert, my oncologists were an expert. We're having this conversation today because of those treatment choices that we made. And it was all based in information and knowledge and data. It started with a rash on my arms and my legs, spread to my torso shortly thereafter. Then came the joint pain, randomly small, large joints, especially right after an infusion, severe enough to keep me awake at night and render me unable to sit still for very long, quite frankly. Then was the tachycardia, an elevated heart rate. My oncologist, when I reported this, said, well, one of the chemo drugs that you're on actually is known to cause a slightly elevated heart rate, but I'm going to send you to a cardiologist in the James anyway, just to be safe. Turns out that cardiologist was interested in immunotherapy too. How lucky did I get? And so while all the testing that he performed said, nothing's wrong with you right now, he said, let's keep watch because the immunotherapy you're on is known to cause severe inflammation in patients' hearts. But I didn't look like those patients. All of the data we had about those patients didn't look like I looked at that point. So my care team was a little bit less worried at that point. Then came the first incident that would be a repeating pattern that would land me in the hospital in the ICU repeatedly. We woke up at 2 o'clock in the morning. I had a fever of about 102, had an extremely elevated heart rate of 190 or more beats per minute, terribly low blood pressure, and really bad joint and muscle pain. In the ER, my treatment consisted of IV fluids, high doses of Tylenol and ibuprofen, and IV antibiotics. Why the antibiotics, you might ask? I had presented like a patient who was septic, a severe, systemic, life-threatening bacterial infection. So those docs, upon seeing me, knew that they needed to act because if I was septic and they didn't treat me with antibiotics, it would be life-threatening to me. So it all made sense. But they never identified an infection. And so after several days in the ICU, I was discharged to go home. That pattern would repeat itself several times. Patrick started bringing me unmatched socks in the hospital. And after my 5th and final dose of immunotherapy, the last time that I was rushed into the ER, my heart rate was over 200. My blood pressure was through the floor, as the ER doc would say. Severe muscle and joint pain, swelling, and my fever was over 104 degrees. So I was quite seriously ill, and they actually kept me down in the ER for an extended period of time, longer than they normally would, because they started 2 IV antibiotics, just in case, because of how high that fever was, and they wanted to monitor me. But there was a very astute ER doctor who listened to us, listened to me in my slightly rambly state, but more importantly, listened to Patrick, who emphasized it's not what you're thinking it is, look deeper. So she went back and she looked at my record and she tested cardiac troponin. So troponin is an enzyme that's used to detect and monitor damage to the heart. And sure enough, there it was. We finally had an answer. I had cardiac inflammation and damage and systemic inflammation. And at that time, my entire care team basically agreed, yeah, that's probably your immunotherapy doing that. So got done with all of that, got discharged, but the story doesn't end there. I ran a fever for 7 weeks. 7 weeks. Patrick was a sleep-deprived saint during that time because I required round-the-clock anti-inflammatory medications every 6 hours on the dot to keep me alive, quite literally. After we got through that, at that point it had delayed my surgery and sent my oncologist calling lots of her colleagues around the country to ask, have you seen a patient that looks like Kara? Because at that point, she certainly had not. And then I got through surgery and started developing additional side effects after the fact. Finished treatment, so we're no longer anywhere near an immunotherapy or even chemotherapy. But I developed what thankfully was temporary autoimmune attack of the muscles that allow my eyes to function. So I couldn't focus my eyes, which for a pathologist is scary. Again, thankfully temporary, so my eyeballs are great today. But I now have severe dry eye. I have periodic skin inflammation that's both not pretty to look at and quite painful. My joints still hurt all the time, all the time. My muscles hurt. I'm still fatigued. And I still get heart inflammation sometimes. To this day, I can't get vaccines because boosters flare my cardiac inflammation, and it's dangerous for me. What's struck me about this whole experience is that in 2021 and 22, everybody was doing the right thing with the information we had at the time. None of us really knew what we were doing. I was an expert in the room, remember? We had no idea. We had no idea. We now know that what I had has been sort of colloquially named triple M, myocarditis, myositis, and myasthenia gravis. Those are inflammation of your heart muscles and an immune attack on the area where your nerves and your muscles communicate. Again, the last one was temporary, thankfully. But there hadn't been a patient with that had looked like me. So my care team, oncologist, rheumatologist, cardiologist, one very inflamed pathologist, we actually published a small case series to get that information out there to help other oncologists recognize the cares in their patient population. Science and medicine have done something really, truly extraordinary with immunotherapy. Oncologists are able to save patients that otherwise wouldn't still be here. And if you think about it, chemo was exactly like this once. Everyone was afraid of it because it was so terrible. But now, oncology teams have ways of managing those side effects so that they can get their patients through treatment relatively easier than in the past. Immunotherapy doesn't have to be any different than that because rheumatologic drugs are widely available and could be used to manage autoimmune inflammation in these patients. We are extraordinarily fortunate here to have Dr. Alexa Meara managing patients like me and those with the other stories that you've heard. But it wasn't Dr. Meara who recognized the autoimmune nature of what was happening to me in the first place. It was an attending rheumatologist who was sent into the ICU to take a look at me. There are rheumatologists all over the place, in small community hospitals everywhere, with access to those extremely critical medications and access to experts like Dr. Meara to guide them in the use of managing patients like us. So to the oncologists, I would ask you to have open, honest, genuine conversations with your patients. Show them the data and make them partners in their own care. They could be critical in identifying early these situations that require medical intervention. Preemptively build those multidisciplinary teams, because then you can say to your patients, this is the gold standard of treatment for you. These things could potentially happen, but when and if they do, we're ready. We have teams. We can continue your cancer treatment, and we can give you the best outcome possible. I want you to understand that is hope you are handing them. And then to the patients and the caregivers, trust your guts. Trust your instincts. You are the ones living in your body. You are the ones watching your loved ones go through this. If you think something's wrong, it probably is. Trust that feeling in your soul. You have a right to ask your care teams to make you a partner in your own care, because it's you. Learn, absorb, gather the knowledge, because knowledge itself is hope. Thank you.
want to start with both of you. Just what do you feel when you listen to those stories? Like, we'll get to the specifics of the science and the clinical care, but like, what's inside you when you hear such powerful testimony?
You want to go first?
Yeah, I'll go first. I mean, I think powerful is the right word. I think, when you hear it from somebody who's lived it, and telling that story in really granular detail in a way that you can envision that, that happening, that helps you. I mean, I think about immunotherapy and cutting edge science and what we do at the James. I think about that all day long. And then I hear your stories and it's suddenly like 10 times more real than the real that I feel every day. And so, it does that for me, it does that for everybody. So I think these kind of stories, they make it really real.
Absolutely.
And so I would say, and to add to the powerful, is the hope, is that you're here, that the James is a partner to the foundation, that this is seen, that immunotherapy is amazing. And maybe we can even make it 1 + 1 = 3, right? And that kind of thing. And that to me is such a huge opportunity and so exciting, because the idea of living and living well can be done. And we can do it all together. And that just, I don't know, I think it's really hopeful. And it's interesting, the foundation started after a random meeting with a bunch of oncologists and some subspecialists interested in this space about 3 to 4 years ago. And we created a research consortium called ASPIRE that is the Alliance for Support and Prevention for Immune-Related Adverse Events. And then we started to have meetings and more people started to join, and then we're all in an academic institution, so then we break the free Zoom because there's more people and we don't actually know how to corporately have anything because we're academic doctors. And then I was invited last year, I think it was last year, to give one of the James State of the Cancer, or about this update of the clinic that I was doing. And then my friends of Alexa, and one of my best friends, Monica, who was like, all right, we got to make you a real boy. We got to make you a foundation, because that's how then you can get the funding and the support and you can do this. And so in a year, this foundation's only been here a year, we are here. And to me, that is just, that's how, and this is fast for medicine. But the immunotherapy, the new drugs of cellular therapies, the bispecific treatments, we don't have to talk about all those right now, but the idea is they're moving at such a rapid pace. And so the fact that we can also keep up a little bit with the living well, I think is such hope.
So you just touched on, you said fast, and one of the notes that I wrote down as we were listening was the word speed. And we're sitting in a place where we have access to this incredible cancer program, one of the largest in the world. How do you think about keeping up with the speed at which things are changing? Because we're so fortunate to have these new therapies, as we heard, and yet they come with challenges. I would imagine that speed is an issue, but also an opportunity because we have such resources here.
Yeah, I'll take that. I'm going to answer, and then I'm going to ask you a question. Yeah, I think, so oncology's never been moving as fast as it is now. I look back over my career as 20, 30 years, and it just keeps getting faster and faster. The kinds of things that we can do just get bigger and bigger, and we're impatient, right? We want to go, right? And so we want these therapies. We want to create more survivorship. We want it all, and sometimes we end up like these stories told very eloquently, like almost ahead of ourselves, right? That in a space where we don't really know entirely what we're doing. We know a lot of what we're doing, but we don't know everything. And I think that we have to acknowledge that and be honest about what we know and what we don't know, and brave enough to really take it on. I thought some of the stories were really compelling in how you all witnessed how different people approach this when you're at that edge of, we learn a vast amount in medical school and residency and fellowship training, and you think you know everything, and you always realize you don't know everything. Especially in academic centers, we live at this edge of the stuff that we know, and then you can see over the horizon to like all the other stuff, because there's always more, right? So my question, though, for Dr. Meara
ready.
is, then there are a few people who don't just look over the edge and go, I'm going to try to figure out the edge. They just like plow right over.
That is probably the most accurate statement, yes, on so many levels.
So what makes you, I mean, you're like in the frontier, right? There.
Such a loaded question. But I will. So to be really honest, it's actually simpler than you think. What makes me in the frontier is, one, I've always been interested by difficult problems. And being a rheumatologist before I entered the James, it's still what I did. I ran a multidisciplinary vasculitis clinic, which Dr. Fussner was in this room, and she may have already left, as a pulmonologist here. And that's a relapsing remitting, so coming and going, chronic autoimmune disease, right? I spent my entire life managing autoimmune disease, this idea of remission on drug. That like, you can do all the things you want to do, however, unfortunately, the genetics that you were given, this is the reality. To do all those things, you have to be on a medicine. And I like to solve problems. And so I had a reputation at OSU to solve problems. And so what was more complicated in the beginning than a cancer patient and an autoimmune disease at the same time? And so I saw this, and everyone's like, well, it's oncology. And I was like, well, we don't know what causes psoriasis. Why? Now we just know that cause. And it just was like, we can do this. I have these meds. And I don't know, it just kind of clicked. And I can't swear, but I originally wanted to name the foundation just because it's hard. It doesn't have to be choice, X number of 4 words, but miserable. Because I couldn't fix the cancer, right? I couldn't fix that, and that was bad. But you know what I could fix? I could make their skin better.
Yeah.
I could make their joints better. And then it just kind of exploded. And then I had patients regretting living. And I was like, well, the one thing we've done really well in medicine is we've got great drugs. Mm-hmm. And so, I mean that well. And so and then it became this idea of, well, just because that drug is in that box over here, why can't it be used over here? Like, the indication to me never mattered, because it was about what the drugs do. And then that kept working, and then more data, and it was verified and validated. And then so that's kind of how we got here. And I think it was just the patients. And if that was you, right? Like, if that was me, I'd want someone like me to make sure that I could walk up and down stairs or do those things to make it less miserable. And so, if not me, then who? Wasn't it the Lorax? Yeah. Unless
That's right.
I'm not yellow or have a beard.
Clearly, there are many people in this room and far beyond who are grateful that you took that step, leap, or pushed down the wall and the door. And I think there's so much more potential. And
so, absolutely.
So I'm curious for both of you to think about if individuals like Cindy and Rich and Jody and Kara were diagnosed a year from now or 3 years from now, what do we imagine? Like, what would we want? What's the end goal so that everybody gets access to whatever they need to enhance their quality of life during therapy and after?
You want me to go first? Okay.
Yeah.
I think it's kind of like if you go to a mechanic and you say your car has a noise. And I'm going to go to a car, right? And the engine's broken, and they replace the tires, and you're like, but the engine's making a noise, right? Or if you have your house redone, but you also need a plumber, an electrician, right? And so I think this is an opportunity in the sense of there's a reason why subspecialists were made, and they have a different series of training and expertise. And I think this is the first time in patients really living longer that in the ability to manage these autoimmune side effects, that oncologists and other subspecialists stand together at every moment, at every time, right? Because usually, you got the cancer treatment, and then you kind of see it, and now it is, oh, you have a pre-existing condition. We see the patient together and to move that forward. So I think it's this really collaborative effort of seeing the patients together, having almost a plan, because I think it's unfair for an oncologist to be like, hey, this is a great drug, you're going to live forever. However, at any point you could have a side effect. Like that's not shared decision making. But what can be is things will happen, and I'm here and I have a team. And these are the people on the team, and so if you see that person, that's what that person's going to do. And ideally we won't need them, but if we do, they're here. And then kind of that subset. And so it's just a little bit more standardized. I think to the point, I think it was Rich that said, I then saw me, and he was like, well, who is she after I saw that person? And I also understand when you're in the hospital, there's a lot of faces you have to see. But I think that's the idea, that it is just collaborative. And it is, the oncology is leading the cancer treatments. And, we're here to just help make that shine, fundamentally, right? I'm making the shiny stone sparkle.
Yep, exactly. Yeah, I think like you said, it's, I think a future where, people are willing to just really be curious, understand that they don't know everything, and that they don't have to know everything, and that they have a colleague. We can phone a friend, right? And that is the way you practice medicine today, and to do so with humility, and without feeling like you have to have the answer, because that's just not what medicine is anymore. And I think it was Kara that said it really well, that I think 5 years from now it's going to be completely different. Like we'll know a lot more about how to use these medications, as we do with chemotherapy. The nausea in particular with chemotherapy used to just be completely rate limiting, and we can control a lot more of that today. Right? We will learn how we do a lot more of these things as we go forward, and then we'll keep discovering that edge just keeps moving, and we still need experts who are working out in the frontier.
And I think to that point of you saying about nausea, and I'll just give a shout out to the industry partners, it is also about those silos being broken down, of the drugs in different sizes. The indication is not what matters, it's how drugs works and how it can be combined to really be 1 + 1 = 3, right? Those nausea drugs then moved over here and in a different way, pick a different area. And I think that willingness to then partner, again, with like the James, the foundation, to be like, okay, we've got these drugs, I also own these drugs. These can be used together. We can develop trials like this. Mm-hmm. And this actually is a benefit for good. And again, may even be a 1 + 1 = 3. And that at minimum, it's a 1 + 1 = 2. And I feel like that's really great.
I think, one of the things that I heard so clearly was this notion that in survivorship, you want to make the best decisions you can make for yourself. And I think Kara may have said knowledge is hope. And the more knowledge and the more options that we can give, the better, right?
Correct.
And every individual story is unique, and every cancer diagnosis is unique, and every journey is unique. Dr. Rathmel, I'm curious, most people here probably know that you came to the James from the National Cancer Institute. And so as the director of the NCI, you looked across the country and probably around the world. Any insights into what's happening on this front beyond Central Ohio? And are there others that are leading? Are we leading? Sort of, how do you think about the landscape that exists in this field? Yeah,
it's moving fast. Back to the comment that you made before. I think that's the number one. It is moving in all cylinders, and a lot of the medications that were talked about today are really what 5 years from now we'll consider first generation. And they're targeting T cells, but we're now looking at all different ways we hit T cells and NK cells. And I won't get into there's a whole host of cells in your immune system, and it's like a really highly orchestrated machine. And right now we're just pushing our thumb on one of them, and we are going to be able to do all different kinds. I mean, it's crazy out there. I would say the James is right in there. This is a worldwide effort, but particularly the Peltani Institute for Immuno-Oncology has helped have us have a really big footprint there. But our clinicians are advancing these really, really quickly as well. So I guess the thing that I would say is, keep your eye on immuno-oncology. It's just moving into every space that we have, and we have to learn how to do it right.
Right. And How do we scale Dr. Meara?
Yes.
I don't know that the world needs more Dr. Mearas. I know they kept saying that.
No, it does.
No.
But I'm sure, but in all seriousness, I'm sure you're in demand, right? Your time and you're lecturing and you're speaking and you're sort of trying to lead this field through this new foundation. You know, that's a beautiful thing, but it also comes with challenges, right? You can only do so much.
I do appreciate that. I think that's the idea into the education. It is, how do we take this and how do we, you're not going to recreate entire fellowships. You're not going to retrain every doctor that's an oncologist. And so it is, how do you take training that exists in different things and how do you augment it to add a question or reframe a thinking that was a previous anchored that we just maybe have anchored just because we did. And that's kind of the goal of the foundation, as well as partnership with the James, of how do we do that and how do we partner to be able to expand that out. Like there's a goal to have a rheum-onc fellowship, right? So you've finished in rheumatology, why I'm here, that's the next step. And to continue to do those trainings and to expose that in the sense of how do we ensure, to your point, that this can be reproducible? And I think some of it is, again, you really eloquently said, the willingness to learn, but about this idea of opening the door to education, to ask what I don't know, and then go, oh, well, that exists, I can use that. Or I'm gonna phone a friend, right? And be like, and that okayness in medicine, and I don't, and I think the reason of the foundation is that the James are all here together. But when you're in the community, I'm not sure what network everyone has, and it's very unique. So it's like, how can you reproduce that?
Yeah, and I think that's something that obviously came up through the individual stories too. People feel so fortunate to have the James here, right? We used to talk about people drive by it all the time and never imagine needing it. And we're all so fortunate to be in this community, but 80% of patients are treated in the community, right?
Correct.
And so they're not at an academic medical center. And so how do we make sure what gets developed here gets disseminated and translated into the community? Okay, we're gonna open it up to questions because I know we have people in this audience that have great questions for our two special guests. So I'm gonna start with Ruth.
I'll just kick it off with a question. Thank you all. Can you take us down just a quick journey around to, because I've worked with you a little bit, rheumatology is like a million colors. And you're like an artist, and meaning you get to pick and choose. And oncology is a little more straightforward. And talk to us just a little about the trials and the research around how do you change the mindset or test those rheumatological drugs that you're using? It's very
actually,
nebulous.
It's really interesting.
Thank you. And please, anyone else, come up here and ask a question. I'm just getting it started.
It's actually a really interesting question that I think I've really delved into in the last 3 years to be like, how do I marry these worlds? And in rheumatology, often these diseases are not life-threatening, right? They were at some point many years ago, but we've gotten better, and we've gotten a lot targeted. And so my entire training, as I think I said this a little earlier, is this idea of manipulating the immune system just enough to make whatever their syndromes are not be an issue without causing harm, right? Making the immune system too bad, but that could be for life. It could be for 20 years and 30 years, right? And so the expectation of when I sit with a patient and say you have rheumatoid arthritis or lupus or vasculitis is that this is, you and I are going on this journey now forever, unless you move and we find you a new one, rheumatologist, right? And to those things. And so it is, that expectation is upfront, and the different thing is because the immune system is unique and everyone's slightly different, there's a reason why you see the commercials for 20 different rheumatoid arthritis drugs. Like, we haven't figured out which drug works for which patient. And so I'm used to going, this is what I'm going to try first. When that one fails, we're going to pivot to that one. And when that one fails, I go to that one. And at the end of the day, I've got 50 drugs. And it doesn't matter the diagnosis. I'll just pivot through the drugs until I find the right one. And I think that framework, right, when you get diagnosed with a cancer, and I do not want to speak for oncologists, so please, correct me if I say anything, right? If you have breast cancer, there's a framework. And this is breast cancer, and these are the treatments. It's not, hey, I have 7,000 drugs over here. I'm just going to willy-nilly pick one of these, right? So it's a very different way of thinking. And so when you start to marry those together, what I realized is that it's like, how do you marry this chronic uncertainty and about a mechanism of action of drug with certainty and very specific resources, right? Those, in that sense, it's almost like they're playing two different games. Like one's playing baseball and one's playing soccer, and we're on the same field that's volleyball, and we're like wondering why this isn't working. And so I think that's the opportunity of there's a different subset of drugs over here with different things of the immune system, and it's taking one system and literally marrying them together. And like any marriage, there's rough spots. It doesn't always go as great as you would like it to be. And so there's ups and downs, there's learning of how you learn how to, to work together in that sense. Because, if I look at Dr. Rathmel and say, hey, it's fine, I got like 12 drugs, we'll fix one. We're like, well, which ones? And I'm like, well, this one, and right, that's a very different of this is the guideline and this is how we treat that. And so that uncertainty married with the certainty is, I think, that little bit of a push-pull, but that opportunity to be able to do that together. And you couldn't have this opportunity if people weren't living.
Right.
Yeah.
Like, we couldn't be here to talk about life and how to treat you to have evidence to live your life if you weren't alive. So I think that's the most important thing. We wouldn't have been here. I don't even think we could have been here 10 years ago.
Yeah.
I do want to just interject that I think the marriages we heard about today were pretty.
No, you're right. You're right. They're wonderful. You're right.
Pretty inspiring, all of your relationships. What other questions do we have from the audience? Don't be shy. There's a microphone. Come on up. Come on up.
A lot of the stories today were very triggering for me. And one of the things, when you lose your mobility, your world gets real small and real dark real quick. So that was triggering. But as you know, Dr. Meara, I'm a patient of Dr. Meara's. And one of the things I would just remember, I've never said why me with cancer, but I did say why did my immune system attack things that were healthy? Mm-hmm. And, when we found out, in the commercial, Keytruda may not be right for you. Well, it was not, and had a lot of trouble with that. But one of the things, when you're going through chemo, and I had both chemo and immunotherapy, and I only had 2 doses of immunotherapy, you always have that chart the oncology team has for you. If you have mouth sores, this is what we do for you. If you have constipation, this is what we do for you. If you have nausea, this is what we do for you. So when someone is on immunotherapy, there should be something where if this happens to you, this is what we might look at. If this happens to you, this is what we might look at. When I go to the ER and I have a temperature of 104, and I've been on immunotherapy recently, maybe we should be looking at some other things other than just pumping me full of antibiotics for hours and hours and hours.
An addendum chart.
Like something like that can say, hey, if you're on immunotherapy, asterisk, maybe look for these things also as well. Because one of the things that I noticed, when you are at your absolute most vulnerable and weakest, you have to be your strongest advocate. And it's hard. It's really hard. So, and if it wasn't for Dr. Meara, I would not be walking. I was in the wheelchair too. And if it wasn't for her listening to me and finding some ideas and trying things, it just made a complete difference in my life. So, thank you.
Thanks for sharing your story.
Yeah, I think that it raises some, along with the other stories that we heard, the importance of, recognizing and speaking up that, hey, I'm on immunotherapy and this might be different. And fortunately at the James, our ER doctors are well versed in this. People, have experience. If you are on vacation and traveling through somewhere, you might come to a place where they don't know, right? So we will eventually get to the place where this is a little more of a playbook, but you're absolutely right. We really need that playbook here.
It's actually very unique in terms of having physically the ER located
Yes.
in the
Absolutely.
James, which
And they
in
actually
a lot
have
of places doesn't
ER
happen.
doctors that research
Right.
how cancer patients come in and how to do that, to be able to do that, which is also really unique.
Yeah.
We can make a chart. That is a doable thing we could take from this. That a
Practical.
chart is a fixable thing.
Absolutely. Other questions? Come on.
Thanks, everybody. Thanks, patients, for sharing your stories. I know that could be hard. I have a question. Is there yet a national registry for patients on immunotherapy for cancer? Because that seems like a really simple, and in our era of AI and big data, that seems easy.
Does the national one exist?
Correct, yes.
No, there is an NCI one that was following patients with immunotherapy that gets toxicity. And then most of it is pretty siloed. Obviously, European countries that are smaller, as with more socialist medicine, and they have a patient. In certain countries, you actually have a number, and it follows you through your whole life, and so it's a little easier to do research in that sense. So yes, but I do think that there is an opportunity, and I actually think with the CAR T, some of the newer drugs out there in cancer, I think they've learned from that, and they've done that significantly on a wider level.
Yeah, it seems like a no-brainer. I mean,
Yeah, it's no brainer, but it is complicated to have that many and to know what to ask. So the program that was at the NCI was sort of cohort based, so it was bounded. Yeah. It had a certain number of patients, and it collected that many, and then it was done. We learned a lot from that study, but there's still more. And so, how do you know where to find that information? So, who talked about AI? Yeah. So, I think that going forward, there's a real opportunity to be able to collect information that's not necessarily like the structured fields. We know what we're asking for, but if you don't know what you're looking for, you don't know what to ask for. And so that sort of more wide open opportunity to find out what other kinds of associations there are, that's going to take more than some of these registries. It will really take things that collect real world evidence data and utilize AI to get to it. So I think that there's real promise there.
thank you.
Great suggestion. I'm curious too on the AI front, given what you just shared about how many options there are.
Yeah.
Right. So tell us a little bit more about that. If there were, let's just say there were 100 patients,
yep,
and they were all treated on immunotherapy, what percentage of them would, in your practice, need some type of drug, and how do we get to a place to use technology to identify the drug that's going to work before we have to try 6 or 8 or 10 of them?
True, but I think to answer that question now, I think is less, because I think if as we get better in understanding these and we better early detect, I think minimizing steroids and starting a more targeted therapy. So I think of it like this: immunotherapy unleashes the immune system, and I think of it somewhat like a tired toddler. Sometimes they fall asleep. Sometimes they circle around screaming for hours, and it's miserable for everyone. And so when it's the caveat, which you never know when that's going to happen, you have to focus it, right? If you can get them to calm and focus. So if you can help the immune system focus on the stuff you want to kill, the bad things, the cancer, and then try to minimize the effect of the things they shouldn't, that makes that a lot easier to do. So I think eventually what will happen is significant combinations of drugs to be able to do that better together. I think of this and how the example that I think that it lives in this world right now is actually juvenile idiopathic arthritis. And bear with me for a second. How you define kids that have arthritis is actually by their parents. So if your parent has psoriasis, though the kid may not, you're treated like psoriatic arthritis because of the genetics. So it's almost what I'm going to call these large buckets of like who you are, what your genetics, what you're more at risk for. This combination of drugs is going to be better for you. And so it's a little bit of a to be able to do that, and that's how we in rheumatology choose those drugs. Though I could go through all the 50, and every now and then we do. For the most part, usually the first 2 you figure it out, or we wouldn't be very good at what we do. But that kind of idea. So I think that's this idea of now with immunotherapy, the patient's genetics, their comorbidities, what they come with, their family histories, their predisposing conditions now can be exacerbated, but you can help manipulate that to allow them to have better success. Does that make sense?
Yes, absolutely.
Was that helpful?
So we have time for one more question if anybody would like to ask it. Otherwise, I will ask the last question. No, don't everybody jump at once. Okay, so we talked a little bit about this earlier, but over the course of your career, both of your careers, you've seen progress, right? So we talked about chemotherapy. I mean, there are certain cancers where they have now done trials to say, what's the least amount of treatment we can give and still achieve
Correct.
the best outcome? How fast do you think that will happen as immunotherapy moves forward?
Oh, how fast will it keep moving? Oh.
And how fast will we be able to sort of really hone in on, hey, this is the absolute minimum therapy in order to preserve the ultimate quality of life?
Yeah, it won't be fast enough. I mean, let's just start there. You know, I think we have to learn how to, you know, maximize cure first, and then be able to bring it down. I think we fortunately have the you know, the hindsight to know that those kinds of effects studies can really make a big difference. But they're slow. They're not paid for. They often take a lot of patients to prove that you can get away with less. There's a lot of sort of risk tolerance involved there to say, you know, do we really want to, you know, back it down? Do I want to be the one that takes half the dose? You know, there's a lot that goes in there. We absolutely have to get to that point because you know, the side effects you all described are you know, ways we don't want this to end. So we want to be able to have, you know, finer tuned control. So how fast? As fast as we can.
Yeah,
for
I
sure.
know you're impatient.
No, it's a little bit like we're like making the car as we're driving it at the same time right now, and that has its perks as well to get to the end, but it also comes with some strong learning curves. And so yeah, I think that's a huge opportunity in looking at how we do this to be able to do this better, because it is moving fast. And I think with AI and the approach of the singularity and whatever that means, that is, and how do we really use that in medicine? Because there's so much data there that we somehow magically don't know how to extract. It's kind of like a black box right now. So I think there is a lot of opportunity to be able to pull that data out to say things that may then be easier than all these future trials.
Sure.
How can we look back at what we have and look back at it meaningfully to then be able to inform, because of the unique healthcare way that we're in life right now, and the dollars to make it as meaningful as possible to have the most impact.
Well said. So in closing, I just want to say thank you to everybody in the room, because I know everybody here is personally and or professionally passionate about this. And I especially want to thank the two of you. I mean, we are so fortunate to have your individual and collective leadership at the James and the foundation, and the world is a better place because of it. And so in saying thank you, I also want to make sure everybody here knows that today is Dr. Meara's birthday. And so we have cupcakes. There are cupcakes in the back. There are cupcakes up here.
Oh my gosh.
So,
they're going to make me eat on stage in white. This is a terrible plan.
We're thrilled you were born. We're thrilled you ended up in Columbus, Ohio. And really just excited to see the future. And again, thank you for sharing. As a survivor, I was beyond moved, and everybody deserves the chance to live with the highest possible quality of life. And the fact that you're willing to stand up here and share really means a lot to all of us. So thank you so much.
Thank you. Thank you.